All right. Well, welcome back, and thanks again for joining me for today's webinar on laser therapy for chondromalacia patella. Just a couple of housekeeping things I'd like to mention. The webinars I do are always recorded. People always email me and say, "Oh, I missed it." If you register, you should receive an email within a week or so with a link to watch it whenever you want, and eventually they're uploaded to our website. So they are available even if you can't join in live. But of course, if you join in live, you can ask questions, which may be advantageous. So today's topic is on chondromalacia patella, a pretty common condition that I think a lot of practitioners treat. And today's webinar is more of on the professional side for healthcare professionals, although obviously anyone can listen in as well. So I'll talk a little bit about the anatomy of the area and then get into the epidemiology, pathophysiology, etiology, and the signs and symptoms of chondromalacia patella, and then specifically on the importance of adding laser therapy, low-level laser therapy or photobiomodulation therapy into the mix because it can really help a lot with cartilage repair, and I'll explain that as we go along. And then I'll get into using our equipment to treat this condition and what kind of approaches you might take, and then we'll have time for a Q&A at the end. As you know, the patella is the largest sesamoid bone in the body. That is a bone that's suspended in between a tendon or a ligament, and it only articulates with the distal femur at the patellar notch. Obviously, it protects the knee, but it's also really important to lengthen the lever arm of the quads. It also increases the area of contact between the patellar ligament and the femur as well. We all know what it looks like, but I just want you to pay close attention to the underside surface or the articulating surface of the patella. There you can see it. It has quite a few facets. In this diagram, it shows, I don't know, like 7 facets. I don't know if that's really real or not, but there's a lot of areas, specific areas where it articulates or makes contact with the articular cartilage of the femur. And this is where we see the degradation, especially on the lateral side. And if you look carefully, you'll see that there's larger facets on the lateral side compared to the medial side. Just so you can visualize, which is really important when you're doing laser therapy, the surfaces, you can see the purplish color is the hyaline cartilage, and you can see the different views. So it gives you an idea that if you use laser therapy and put the lasers sort of right along the edges of the patella and the condyles, you can get light into and around the cartilage in that area, and that's really important. As I mentioned earlier, the primary function of the patella is to increase the lever, and this occurs during knee extension. So it essentially increases the angle with which the quadriceps tendon pulls the shaft of the tibia. It also functions to allow for smooth movement in knee flexion and extension, obviously, and it would protect the anterior knee joint. So there's several ligamentous structures that support the patella or the patellar area, including the medial patellofemoral ligament. You can see that's in the yellow, and the medial patellomeniscal ligament, obviously connecting to the meniscus, that's in green, and then the medial patellotibial ligament in that purple area. So that's on the medial side. Lateral side is a lot stronger, mainly because of the iliotibial band and the lateral retinaculum that kind of comes off of it to support the patella and help the patella track, as well as the lateral patellofemoral ligament, as well as the lateral retinaculum. Sorry, I got all that confused. The lateral patellofemoral ligament is on its own. Then there's the lateral retinaculum, which is kind of part of the iliotibial band as well. But all of these structures, my point is, all of these structures provide a lot of support on that lateral side, and this is the problematic side in chondromalacia patella typically. So as I mentioned, these passive structures, that is ones that are non-contractile, are stronger on the lateral side. The iliotibial band in particular can be under a lot of tension, especially if it's a tight tensor fascia lata. So this will cause excessive lateral tracking and or patellar tilt as well, which can lead to grinding, you can imagine, of the underside surface of the patella, perhaps causing chondromalacia patella. Really important to understand the blood supply. I tell you why, is that one of the ways you're going to try and help chondromalacia patella is to stimulate the blood that's circulating around and feeding into the patella to provide its nutrition, including stem cells that are, of course, floating around in your blood. So the main branches that supply the patella are branches of the patella or the popliteal artery called the genicular branches, and then there's superolateral, medial, inferolateral, medial, and descending and anterior genicular arteries, which I'm sure everyone is well aware of, but maybe you haven't looked at those lately. But if you can see, there's quite a few branches that supply the patella, and they're all coming from the back of the knee. So you might think, oh, that's interesting. What does this have to do with anything? Well, one of the placements for light therapy or photobiomodulation I'm going to recommend is the popliteal region, even though it's literally on the opposite side of the patella, to help stimulate the blood flow and specifically stimulate stem cells to help in the repair process, because they feed in and around the patella and indirectly the cartilage of the patella. I hope that makes sense. So the superior 2/3 of the posterior articular surface of the patella articulates with the anterior surface of the femoral condyles. The lateral articulating surface is actually quite a bit larger. I kind of showed you that earlier. But the medial femoral condyle is larger and projects further anteriorly. You can kind of see that in the diagram here than the lateral femoral condyle. So what's really important to understand here is that the articulating surface of the patella is covered with a very thick layer of hyaline or articular cartilage. It can be up to 7 millimeters in thickness. So that's really thick. And it's thick because it helps to protect and cushion the patella and the femoral condyles when we're doing all the stuff that we do. When the knee is straight, the patella sits, I don't know if you can see it here, the patella sits in the groove sort of at the bottom of the femur. And then as the knee bends, the patella actually tracks and moves along the groove in the femur. I think we're all kind of aware of that. Chondros is Greek for cartilage, and malakia, or I don't know how to pronounce that in Greek. I'm not Greek, means softening. So softening of the cartilage is the deal in chondromalacia patella. There's some other names for it. Sometimes it's called patellofemoral syndrome or runner's knee or jumper's knee. And essentially, it's a pathological softening and fragmentation or degradation of this cartilage. And usually it's because of high impact loading or excessive shear stress or repetitive stress, that kind of scenario, as opposed to osteoarthritis, although you can also find this in osteoarthritis, and then it's called OA chondromalacia patella, right? So a little bit slightly different scenario, but more functioning as a result of arthritis. So again, this is a typically overuse syndrome. Usually you see in athletes, especially young athletes, they'll complain of anterior knee pain, more common in females. I'll talk about that shortly. And there's something called patellofemoral pain, which kind of gets confused with chondromalacia patella because it's essentially the same thing, except that it's not quite there as advanced, causing cartilage degeneration. It's just pain because of friction and abnormal alignment of the knee. So it's the beginnings potentially of chondromalacia patella. So that's why it's really important in young athletes. As soon as they start experiencing pain, you don't want that to continue and lead to degradation and wear and tear of the cartilage. You want to catch that and try and help the athlete or whoever it is to look at the problem, the causation, and fix it that way and reduce the inflammation and so forth before you get to the more serious problem like chondromalacia patella. So PFP is patellofemoral pain and CMP is chondromalacia patella. And really, the only way to definitively diagnose chondromalacia patella is through imaging, typically an MRI or what have you, not an X-ray because you can't see cartilage. That's the only way to say for sure. I suppose you could also go in there and scope as well. But if it's been there a long time and you can kind of feel crunching, that kind of thing, you have a pretty good idea as a clinician that there's a problem there in the cartilage. As I mentioned, it's more common in females. It tends to be a lot more common in younger age groups, 16 to 25. And apparently not 1 in 4 young people, especially females, can develop this if they're active. So it's a very common condition. And if you treat female athletes or active young women, you'll know that they oftentimes complain of anterior knee pain, and this is the problem. So it's usually associated with a tracking issue, how that the patella tracks, as everyone knows, and it seems to shift towards the lateral side, increasing the friction, and then leads to inflammation and pain and eventually degradation. And again, the main reason why it's more common in females, as we all know, the Q angle, which is a little bit higher in women, and this increases the lateral pull on the patella. Can also be caused by, or these are some of the other things that you find, is tightness of muscles, including the rectus femoris, tensor fasciae lata muscle, the hamstrings, the gastrocs. And also you may have other issues. So you should never look at this in isolation. You should be looking at the entire lower extremity from the foot ankle complex, probably all the way up to the hip area. So you're looking at the tensor fasciae lata, alignment of the hips, looking at the knee and the mechanics, and then you're looking at the ankle and the foot, because pronation of the subtalar joint, can't speak today, causes internal rotation of the leg, and this will result in malalignment of the patella. Also, you can have conditions like patella alta or baja, which is either abnormally high or lower position of the patella. And this really has to do with the length of the patellar tendon. There can also be, and this is very common as everyone is aware, is weakness of the vastus medialis. So that's something that needs to be addressed when you're treating these types of conditions, and certainly tested for it to see if that's the case. Again, arthroscopic findings indicate that the depth of the cartilage thinning. It may also be associated with subchondral bone changes. This is in more severe cases where there's significant chronic pain in that area. And this can definitely be picked up with imaging. And it's graded essentially. So, stage 1 is just softening and some swelling of the articular cartilage due to broken vertical collagenous fibers. The cartilage is starting to turn a bit spongy when they examine it with arthroscopy. Then into stage 2, there can be something called blister formation in the articular cartilage due to separation of the superficial from the deep cartilaginous layers. Are kind of, I don't know if you ever have seen histological samples of cartilage, but it's layers, right, of chondrocytes and cartilage. And this is what they're referring to. So you can start to get fissures or in a specific area. And there's really no subchondral bone issues yet in stage 2. But as it gets more advanced, then you see fissures, fragmentation, fibrillation of the cartilage. So it's quite nasty at this point. This would have to be pretty severe to be classified as stage 3. And you might start to see some subchondral bone being affected as well because of all the extra stress in that area. By the time you get to stage 4, it's bad. It's crater formation. It sounds really bad, right? Crater formation, vernation of the exposed subchondral bone. More than 50% of the articular surface is involved. You make it osteophyte formation and so forth. So this is long-standing chondromalacia patella that someone hasn't had treated or tried to get help. What's really important to understand is that cartilage itself doesn't cause the pain. There are no nerve endings in cartilage, right? So the source of the pain is more along the other soft tissues, inflammation around the area. So it's a pathological finding or a surgical finding. So fortunately, chondromalacia patella, for the most part, can be healed to some degree, unlike, advanced OA, that kind of thing. And your treatment really is revolving around reducing the inflammation and helping to repair the cartilage. So the goal here is to get the inflammation and pain under control so that you can start to work with muscle strengthening or flexibility, that kind of thing. We all know that hyaline cartilage is, I mentioned earlier, composed of chondrocytes, and they're dispersed in this extracellular matrix. The matrix has mostly type 2 collagen, proteoglycans, and water. This is all kind of mixed up in like a hard gel-like substance. And the chondrocytes produce these proteoglycans, and they're secreted into the matrix. Essentially, cartilage is avascular, right? There's no direct blood supply. The nutrients that supply cartilage, and this goes for pretty much most areas of the body, the hyaline cartilage, is that the nutrients have to diffuse through the synovial fluid, and movement of the synovial fluid helps with that flow of nutrients as well, and blood supply and lymphatic drainage. All of that is really important. We know that photobomb modulation therapy or laser therapy, there's so many names for it, but we definitely want to stick to photobomb modulation therapy, even though I always say laser therapy. You might say, hey, why do you call your webinars laser therapy? Well, because most people still don't know PBMT is the sort of better term to use. So photobomb modulation can accelerate the repair and increase the regeneration of cartilage and improve the metabolism of chondrocytes that are impaired because of inflammation. So I'll walk you through a little bit of the research so that we're all on the same page here. This is a great guest editorial. It was in 2019, so it's not that old. And it talks about the role in general of photobomb modulation helping to treat articular cartilage, not necessarily chondromalacia patella specifically, but well, articular cartilage is articular cartilage. It's written by a couple of medical doctors. And so they mentioned that photobomb modulation or low-level laser therapy using lasers, or yes, that's right, LEDs, light-emitting diodes, they can increase stem cell multiplication and differentiation. That's one of the key ways it's going to help this condition, and it can help modulate the functions of the cells that I mentioned earlier. So they make quite a few references here. I'll go through them very quickly. He references a paper by Bayet et al. Using red light, and it was done on immobilized articular cartilage. So when you immobilize articular cartilage over a period of time, it starts to degrade. And they found that when they use this light, it neutralized the adverse effects of immobilization. In other words, the cartilage didn't degrade because of the immobilization. It helped keep the chondrocytes and the cartilage healthier. Another reference, another paper, they looked at healing of damaged articular cartilage in the knee joints of rabbits. And they looked at different ways of doing that, radiological, biochemical, and they found, again, the articular cartilage in the treatment group using laser therapy it actually helped the healing. Another paper by Alves, I've mentioned this paper before. It talks about joint damage in rats. And they found that both 50 and 100 milliwatts helped increase healing, decrease type 3 collagen, which is the immature collagen, what you don't want in cartilage, and increasing type 1, and I'm assuming type 2 as well. Another paper looked at using 830 nanometers. That's near infrared. That's of course what we use in our equipment on the knee joint of arthritis, of rats with arthritis. And they also found that it preserved glycosaminoglycan and reduced cellular changes in inflammation. So overall, they concluded that photobomb modulation can biostimulate cartilage tissue, and it should be helpful in treating articular cartilage. They made a reference to understand the dosaging. So let's get into the dosaging. This paper is a great paper because they did it in humans. All the other ones were in animals. This paper looked at control. It was a randomized control trial. And what they looked at were patients with chronic OA of the knee. And they not only looked for pain and function, they did radiological assessments to see if the cartilage was actually improved post-laser therapy. So the subjects were either placebo or the laser group. And the subjects, I don't know why I did that there. The subjects had treatment 3 days a week for 4 weeks, so about 12 treatments, right? That's usually what we recommend, about 3 times a week, 1.5 joules per point. Now, they did it for 60 seconds, so their laser would have been a little bit lower power than ours. But I'll talk about how you can get that equivalent of 1.5 joules per point with our equipment. They did 8 points around the knee joint for a total of 12 joules. So they looked at VAS, they looked at the matrix metalloproteinase production, and then they also looked at the collagen itself and the cartilage itself before treatment, 4 weeks after, and 8 weeks after the treatment. And what they found was after 4 and 8 weeks, that the active laser group, the ones that had real laser therapy, showed more significant difference in all the parameters than the placebo laser group. So therefore, they concluded that low-level laser therapy was more efficient in reducing pain and improving cartilage thickness through biochemical changes. So this is the only one I've been able to find really that does it in humans. It's a lot of work to do that in humans. That's why they do it in animal models. But it shows you that you can translate from animal model like cartilage, especially, you know, when you're looking at hyaline cartilage. I mean, it's not that different from a rat to a human. I mean, just look what's going on down in the States with their politics, right? So, you know, those kinds of rats, no, I'm just kidding. Maybe not. So anyway, I digress. So how do you use BIOFLEX? Well, use a standard knee protocol. There's not one specifically for chondromalacia patella. Start with stage 1 as always recommended. If the patient's coming in with really acute anterior knee pain, I like to treat several days in a row. If you can treat 2, 3, 4 days in a row, it's advantageous. Then go to 3 times a week. So you're trying to get it under control if that's possible. You need to be patient because depending on the stage of the chondromalacia patella, if you're looking at trying to repair cartilage, it's not going to happen in a week or two. It's going to take quite a few weeks, if not some months, to really accomplish that, right? So you may get them out of pain, but you still want to repair the cartilage, and that's going to take longer because of poor blood circulation or no blood circulation to the cartilage itself. And then, of course, as you go along, how you use the protocols essentially is you can alter the dosaging. You can change the duty cycle, right, which increases the amount of light coming out. You can change the pulsations of light. Typically, we start low and then start to increase that as the patient's plateau or maybe their response isn't as good as you'd like. You can start to increase it, give it 2 or 3 sessions before you start doing that. So based on the patient response. So mentioned earlier about treating the blood supply. So how you do that essentially is to treat the popliteal region, make sure it's firmly secured and touching the skin in the popliteal region. And this is great for stimulating the popliteal artery and the genicular branches that I showed earlier and how they all come out to the front. By stimulating that blood flow, you're stimulating stem cells, getting them activated or immunomodulating them. And it seems to be very helpful in the repair process in and around the area that you're treating. So before you tackle all the mechanical issues, get the inflammation under control, get the healing process going, and then ease into the exercises and so forth. And the other thing about inflammation is that it's controlled in part by white blood cells. So the more blood that you expose to photobiomodulation, the more effects you'll have on activating white blood cells that control inflammation and actually help to reduce it in and around the knee area that you're treating. Then you'll want to treat the anterior lateral, which is the top picture, and the anterior medial portion of the knee joint. So notice in the top picture, I've covered the patella. And so I'm treating right over the patella and the blood supply. I'm treating the lateral portion of the joint line and around the structures of the lateral knee joint. And the same thing for the medial knee joint as well. If you wanted to, you could increase the time of treatment on the lateral side because that's usually where it's worse by a minute or 2. So instead of 6 minutes of red and 6 minutes of infrared, you could go up to 7 or 8 minutes red, and same thing for infrared. That's another way of tackling this as well. Then the laser probe. Now, most people would be using the near infrared or the LDI 200. They have the red. You could use that as well. The idea behind the probe is not to treat the entire knee. What you want to do with this is drive light so that it goes deeper and hits the tissue that is damaged, in this case, the hyaline cartilage. So you want to, try to treat the undersurface of the patella and the femur if it's affected as well. You can even gently move the cartilage, move the kneecap, medial lateral while you're doing that. So to expose the undersurface, visualize where the cartilage is. Those diagrams I showed you earlier is a good way of doing that, or looking at cadaver pictures, that kind of thing. It just reminds us where it is. And treat all the way around the knee joint. You can treat the superior and inferior portions of the patella as well, but you have the tendon and the ligament in the way, and you're not going to get much light through that. So I kind of think it's a waste of time. I'd rather you focus more on the outer margins, on the lateral medial sides of the patella. I think you'll get more light into the cartilage by doing it that way. So if you want to get about 1.5 joules of energy per point, and that's kind of what they mentioned in that one article. And I think that's kind of what we do anyhow, but it was nice to see a research paper that recommends that. Set the laser probe to 50% power, set it to CW, that's continuous wave. So the light's coming out in a steady stream. So that's roughly 90 milliwatts. That's 0.09 watt. You treat for 20 seconds, you do the math, and that is 1.44 joules. So in other words, you're going to hold the laser for approximately 20 to 25 seconds. That will give you about 1.5 joules per point. And then you're going to treat, roughly every centimeter or so all around the periphery of the joint. And that might be, 6 points on each side, probably, or it depends on the size of the knee. So you're looking at roughly 3 to 5 minutes total treatment time to treat around the patella. Of course, if there's other tender areas or areas that you suspect are problematic, you can treat those points as well too, obviously. All right, so upcoming events, I have a whole slew of webinars here. You can see I'm doing today's, I don't know why I put that one up there. I have one on improving gut health. Then I'll be introducing our BIOFLEX Wave Zone LED panel on September 14th. And then I will do one on long COVID. That should be interesting. I'm trying to get a guest speaker for that one. Maybe my friend, Dr. Ashley Banjan in South Africa will join me for that one. And one on shingles as well, too. So if you have a chance and you're interested, you can sign up for them. Even if you can't make it in live, just register and we'll send you out a copy of the webinar as well. This is your chance to ask any questions. I'll get to that one question so far. But before I do that, if you haven't yet visited, you'll see all our new devices, including home devices, our new mini port home device, as well as our personal therapy systems and our other wave devices on bioflexwave.com. You guys are quiet today. I'm not sure if you're all asleep or what the deal is, but I will answer the one question I have here. And is it safe to use the laser on the knee when there are metal plates or screws or implants or whatever? Will the metal react with the this? So it should not react. It's not a contraindication to treat over embedded metal. And that's really because the light isn't going to heat up tissue. It's under that threshold of thermal reaction, which is around 500 milliwatts of power. So even if it were to hit directly on a screw or an implant beneath the skin, it's not going to absorb the light and cause any heat. So it's not considered a contraindication. Question is, where can I get the stem cell webinar? As a register for it, but for some reason was not able to attend. So again, if you go to bioflexlaser.com, and then if you go to support, you will see the webinars for the professional webinars, and they're there. Sometimes if they're not there, if sometimes I do the webinars for the personal therapy systems, they've been shifted over, I believe, to the BIOFLEX Wave .com website. Okay, so just look for them on our website. They're there somewhere. And if they're not there, they'll be there soon. Our IT guy's swamped, as you can imagine. So they get up there. It just sometimes takes a bit of time. Question is, does laser therapy help to reduce fluid on the knee? So essentially edema, you get runner's knee or you get swelling of the knee. And that's really caused by inflammation of the synovial lining. So when you reduce inflammation and when you treat the synovial lining with laser therapy, it helps to repair that damage that's causing that fluid buildup. So it can help to reduce the swelling of the knee associated with everything from chondromalacia, patella to OA to what have you. But again, you have to look at, it might be chronic swelling, right? So it's going to take some time for repair. And depending on the stage of the issue that you're dealing with, the severity, you may not be able to resolve it 100% completely. It really depends on this whether or not it's really severe or not. Someone enjoyed my rat comment on the politicians out there. By the way, it's a universal thing, whether it's Canadian politicians or American politicians. And hey, look, I'm not saying that I'm pro anyone. I'm just saying that they're all the same in my book. Okay. Help with RA. What is the best? Well, okay. So I don't know if I did a webinar specifically on rheumatoid arthritis, but you can definitely help RA with photobiomodulation therapy. It's going to help the symptoms. It's going to slow the progression down. But remember, it's an autoimmune issue. So there's lots of factors at play there. It's not going to magically go away. There's really good biologic drugs out there, apparently, that are very helpful for it. And, it all depends on the stage that you're at, that kind of thing. But in general, photobiomodulation therapy, and there's some good evidence-based guidelines that suggest it is very helpful for it. We treat it all the time, and it can be very helpful. There's a statement here. I had stage 3 CMP and had laser, 26 treatments in 2003, 100% recovery verified by MRI. Convinced me to buy a laser for my clinic. Jill, that's awesome. Yeah, so notice 26 treatments. You might go, oh my God, but come on, let's be realistic. When you have stage 3, significant deterioration. Hey, by the way, Jill, if you can send me those before and afters, that kind of thing, I'd love to take a look at them. Maybe we can do a case study and get it published. So if you have a chance to touch base with me on that, if you do have that, I'd love to do a case study and see if we can get it published. Can we apply 5 joules for knee OA to get cartilage regeneration? Okay, so I mean, the recommendation is around 1.5 joules, maybe 2 joules per point. I'd start with lower amounts of energy and see how that comes along. But in that range should be okay. 5 might be too much in one specific spot, but there's a range, so it's hard to say what that range is. No one would really know that yet. How many treatments or the care plan? Well, I mentioned the care plan, that is 3 times a week, or if it's acute, 2, 3, 4 days in a row. And then depending on the severity of it, then you're going to be treating for at least 4 weeks, maybe 8 weeks. And that's 12 to 24 treatments, as Jill mentioned. Can we apply 20 hertz to regenerate cartilage? Well, I don't really know if the frequency of light has any big effect on regenerating the cartilage. There's no research on it, so I wouldn't know. We do know that pulsing the light makes it more efficient, and we usually start at 10, 20, 30 hertz, so you can play around with that, but there's no magic bullet number there. And if anyone says there is, it's BS, because we don't know. We just know that pulsing the light can be more helpful. I try and make this as scientific as possible. If we don't know something, I'm going to say it. So whenever you see claims about stuff, be very leery, because other than so far the research is showing for nerves, in the especially central nervous system, 10 hertz and 40 hertz has been shown to be quite effective, but that doesn't mean there's not other frequencies that are helpful. It just shows that the research, they've used those frequencies and it was helpful compared to other frequencies or continuous wave. In my book, at this point, it's more important just to get the light into the cartilage at appropriate dosaging. That's the most critical thing. What's the ideal dosage or placement for Achilles tendonitis with thickened tendon? Well, so that's tendinosis, not tendonitis. And I definitely have some webinars on that, Mahal. So we do have an Achilles tendinopathy protocol. That's what I'd recommend using for that. And when you're dealing with tendinosis, you need to do eccentric loading exercises. It's very challenging to really get it back to where it was because you have to get rid of all the immature cartilage and crap that's built up in the tendon. And that's a degenerative process. So it's like treating OA of the tendon. Very slow process, and you're not going to get it back 100% to where it was probably, but you can help it by doing that. So I'm applying 6 joules per point and getting cartilage regeneration. Well, yeah, I mean, that's great. I mean, it's a range, right? I always prefer to start low and then work your way up if you're not finding that. I'm not sure how you're verifying that cartilage regeneration, by the way. The only way to do that is with imaging. So if you're doing that with imaging, that's awesome to get that confirmation, but you're not going to know otherwise unless you have imaging to confirm that. Yeah, so pulsed or cartilage. So for the laser probe, continuous wave. And I'll tell you why. It's not on there very long. It's on there for like 20 seconds or so. Pulsing won't make a difference. I don't think so. With the large arrays, it's sitting there for long periods of time, the pulsing might have a greater effect. And so that's why we do recommend pulsing, 20, 30, 40, 50 hertz, whatever, you can play around with it. But it's more important for the laser just to have a blasting continuous wave more than likely. But again, there's no one specific answer here. It is what it is, and you can try different variations, but I just presented to you what the research shows us right now. Thanks a lot for joining, everyone. I hope that you enjoyed it. Someone asked me a question in the chat box, and so luckily I saw that. Can you reduce Hagelin deformity in the heel, big bump at the heel? Yeah, you can help that for sure, but that's a tough problem because it's by the time it gets there, it's been developing for a long period of time. You can place the array over that bump deformity, make sure the person's not wearing the shoes that are causing that issue. And it can be helpful, but that's a long-term project there as well too. Question about the nano. Will it get the same effect as a personal therapy system or together with it? Oh yeah, so personal therapy system is going to be significantly better because it makes skin contact. It treats a much larger range, a much larger surface area of the tissue. And there's a lot more variability with respect to frequencies and duty cycles, that kind of thing. For a spot treatment or just a small area of treatment, the nano is pretty good. At least I found that. But if I'm treating I really want to treat a pathological condition or issue, I would go with the nano. You guys are asking me questions not related to chondromalacia patella, so that's okay, but try and stick to chondromalacia patella. Can you treat keloid scars? Yes, you can. You can help reduce the volume of that keloid scar. It seems to modulate the scar tissue in those scars. We've done before and afters and showed reduction of keloids, and there's actually also research published showing the same thing. All right, everyone, thanks again for joining me. I hope to see you at the next one. Oh, I was referring to the patella with the nano. Yeah, I mean, yeah, you could use that for sure. If that's your only option, you could use the nano. I would still prefer the personal system for that. But if your only option is a nano, then I would still use it there. Thanks, Suzanne. Appreciate the accolade. Take care, everyone. Can you use both systems? Yeah, you can. If you don't have the personal system accessible, you can do the nano or what have you. So you can definitely use both systems for sure. Take care, everyone. Have a great day.